When I was preparing this talk, I really wanted to focus on the role of the neurosurgeon. I think there are multiple aspects in where we make a big difference. Obviously, all the way from diagnosis to basically outcomes in regards to survival, and then also with research, with precision medicine. And lastly, I'll touch a little bit about our potential role in addressing disparities. So this is one of the papers that came from my laboratory. It's a perspective piece on what the role of the neurosurgeon is when developing a modern molecular biobank. And really, we have integrated our system so well between the operating room and research. I actually don't separate them in my mind. But basically, for example, certain things have effects on both. So regional tissue harvesting can affect diagnosis because if you send a tumor that is, say, 90% low grade and then one region that's high grade, if you don't separate that out for the pathologist, perhaps there will be a misdiagnosis. And then vice versa, when regional tissue harvesting, for example, for stem cells, if you isolate the subventricular zone, you may have a better isolation for neurosphere cultures. So all of these things are intertwined. So at UAMS, our workflow, there's some preoperative considerations. First of all, we consent all tumor patients for biobanking, and for next generation sequencing. That's standard for all our patients. It doesn't actually matter the pathology. And then surgery choice is another thing. We do obtain tissue from all these various types of surgery. And even for example, we'll talk about an assay of functional precision medicine. We have used the NICO Myriad device in endoscopic cases, not just transsphenoidal endoscopic, but also intraventricular. So you're able to take tissue from all of these options. And we'll talk about some things specific to high-grade gliomas. I highlighted that in green. So we routinely use gliolin in all of our high-grade glioma cases, and that's our standard at our facility. And then with the operative tissue, obviously, we have to send diagnosis to pathology, so that's very much important. I'll touch upon the concept of real-time diagnosis, perhaps moving towards a time that within a day or two, or even the same day, that you'll get molecular markers. And then I'll also talk about a functional precision medicine assay, 3D Predict, which we routinely send on all our high-grade gliomas, so hence highlighted in green again. And then lastly, postoperatively, can we affect precision medicine? And hopefully through some of the cases I'll review, you'll be convinced that yes, we can do that. So here's our modern operating room. We have both microscopes and exoscopes. This is obviously the 400 nanometer light. We use gliolin routinely. This is a recurrent high-grade glioma case. We also routinely use the Myriad device. We have the upgraded system with the temperature regulators. DAX has trained all of our nurses on how to use this, and we routinely use connectomics. So for our research workflow, I think it's very imperative that in the operating room, you're communicating with the pathologist. We typically don't send research until we feel we have a confirmed diagnosis. So it's an interaction between the surgeon and the pathologist. Then our OR staff, as well as the NICO rep, help us with tissue collection. This is an old picture before we've gotten the upgraded system. And then subsequently sending for research. We bypass pathology. So once we give pathology frozen, we send them permanent, and we actually do take tissue from the operating room directly to the lab, which was a fight, but we got it through the IRB. So our research workflow, we tend to be biased. Classically, a lot of times you just send out a big chunk of tumor. We're a little bit biased. We feel that this mechanical disassociation in the OR is very beneficial. Sometimes tumors will undergo subsequent chemical digestions. Classically, you can generate two-dimensional or three-dimensional cell lines, neurospheres. We have started to really not do any chemical disassociation, rely solely on mechanical disassociation to get these little tumoroids, as we call them. You can see this is a high-grade glioma invading. And this is just, we didn't do anything, just further disassociate what we got from the NICO. And then again, just to reiterate, we only send research if we have enough for pathology. So this is an example of doing a mini craniotomy with brain path. And we felt like we will have to send our NICO specimen to pathology. And this is actually Paige, one of our NICO reps, just actually doing that in the OR for us because we wanted to make sure we didn't compromise the diagnosis. So I'll touch upon what is precision medicine briefly. So typically patients come in, they all get maybe the same treatment, they have various outcomes. But now could we perhaps tailor a therapy to their specific tumor and hopefully result in better outcomes? Now, what is functional precision medicine? So functional precision medicine is using the tissue. Classically, precision medicine, you think of identifying actionable DNA mutations. What if you actually took tissue and then tested drugs directly on patient tissue? So current classical precision medicine efforts based on actionable DNA mutations really results in less than 30% of patients responding. So we routinely send for 3D Predict. This is an assay developed by Kiatech. And what this is we send them fresh tissue, we ship it overnight, and they grow spheroids, and they give us a report back in 7 to 10 days. This is a typical report. They actually screen for 12 drugs, and you get this response report. Here's the abstract from ASCO. Lots of different people involved in this work from all over, and some of the preliminary data is very promising. So this is just looking at all high-grade glioma patients and looking at how if the test predicted that you would be a responder, it does appear that you have a beneficial increased survival. And what about the MGMT biomarker? So if you are MGMT unmethylated, some people were still found to be test predicted responders to temozolomide, and they ended up doing better. So this comes to question about what is the best biomarker? Is it functional tissue testing? Is it MGMT? We're starting to move beyond what we classically think. This is an example from a recent patient of mine that I sent. Not all of the tissue was able to form spheroids to the right. So you can see on the left, some of the cells were senescent, and so we weren't able to get the predictive assay. The other thing that we routinely do is incorporate next generation sequencing in our surgical protocol. This is actually the first patient I ever sequenced. She had a very rare tumor type, and I sequenced her because I honestly hadn't seen this before. SMARCB1 deficient sinonasal carcinoma with perineural spread as well as leptomeningeal spread. And we published this case report. This is one of the first cases that ever sequenced this tumor. It's a rhabdoid type tumor, very aggressive. And I had to ask the mother posthumously for permission. And her question to me was, why didn't this test help her? Why didn't it help my daughter live longer? This has haunted me. And I hope by the end of this talk that you can say that I am starting to use NGS to actually affect patients, and it's not just for fun. So some of these cases I'm going to review, I put a little bit of caution tape just because I think at Arkansas we're very much more aggressive than at some places. As Dr. Day unfortunately couldn't give a talk today, but as he would say, a lot of these cases are surgery between two consenting adults. So this is one of those cases, recurrent GBM in the brainstem. When we discussed this at Tumor Board, Dr. Day was like, you should do a middle fossa approach and resect this. And I thought, well, okay, I'll do it. You're my boss. Thank God, by the grace of God, and also gliolin. This was one of the first cases I used gliolin, and I am very much grateful for it. And thankfully, the patient did well, ended up living much longer than expected in my mind, about 6 to 7 months later. So this patient came in with seizures and had newly diagnosed renal cell as well as multiple brain lesions. So this patient was taken for a biopsy because we weren't sure, are these Mets? Is this high-grade glioma? What is this? Intraoperatively, very bloody. We had to stop at a certain point. Final pathology came back as mild glioproliferation. So what we learned from this case was that basically histopathology no longer is what makes the diagnosis. NGS made the diagnosis. So 2 weeks later, his NGS came back, he had a TERT promoter mutation. This was a high-grade glioma. So again, one of the problems is that answer took 2 weeks. So I am very much interested in long-read sequencing, also known as third-generation sequencing, moving closer to getting a real-time diagnosis. So this is another paper from my lab published not too long ago. And basically in this, what we did is look at biomarkers where we actually cut out sections of DNA from frozen or fresh tissue samples, MGMT, IDH1, IDH2, and we used Cas9. We did not amplify the DNA, and also long read sequencing can read the areas that have methylation. So we compared this to other sequencing like Illumina, and we were able to get pretty good results, very comparable to what is currently available. And then looking at the methylation, if you know about MGMT methylation, you know that there's no standard test. People are looking at different CPG regions. And so here we're able to look at a large region across the intron and exon and look at all of those CPG sites. So ultimately, we do think that this may be used long-term for real-time diagnosis. In Norway, there's a group that has sequenced without the Cas9 and gotten results within 3 to 5 hours of diagnostic molecular markers. So ideally, fresh tissue is needed for this advanced long-read sequencing. You can do DNA, RNA, and epigenetics. And I do think the Oslo group showed very likely this is going to be taken to a point that you will get intraoperative diagnosis. Again, just a reiteration that now I don't really think the histology is as relevant as it used to be, because you really just can, as I've showed you in the case before, you can get diagnosis from molecular markers. So here's another case, a 56-year-old woman. She comes in with seizures. She has this lesion, a very small area of enhancement. This patient, again, our standard is to use gliolin. I sent that enhancing region that correlated with the fluorescence separately to our pathologists. Again, this is one of those cases that histopathologically, that area was high grade, the surrounding area was not high grade by histopathological analysis. This patient then came in with recurrence, has this linear enhancement around the cavity with some nodular components. We send for 3D predict for our high grade glioma patients. So gliolin was again very good to differentiate radiation changes, treatment changes from recurrence. And we were able to get functional information from this tumor. So basically, gliolin, I think, is really useful for diagnosis. And also, I think, when upon recurrence, from differentiating tumor from recurrent tissue. So then this patient came in. She is a 60-year-old woman with melanoma. She got diagnosed about 2 years ago. No invasion in the lymph nodes, never been treated. They didn't do any molecular markers. She lives in rural Arkansas. She had 15 total brain lesions when she came in. She was weak, but still ambulatory. This case, I chose to do a MIPS procedure. I honestly don't really know what other modality you would use. Got a very good resection of her largest lesion. I would say at a lot of institutions, unfortunately, you probably would have just gotten a biopsy. We do NGS on all of our tumors. So thankfully, she had a BRAF mutation. This is her scan a year out. So she was started on BRAF targeted therapy. And another thing, because she was rural, I actually radiated her during her hospital stay because I just felt she wasn't going to come back to get radiation. And because I did MIPS in a very small incision, I felt comfortable that she got radiation starting 2 days post-op while she was still in the hospital. I don't think you can really do that with maybe more classical craniotomies. So again, I think brain path was critical for the success in this case. We needed the tissue to diagnose her. Thankfully, she had a BRAF mutation. And then again, just considerations for the patient. She was rural, so I radiated her right after surgery. So we actually do culture both tissue from high-grade gliomas as well as metastasis. This is a group we collaborate with where they're very much interested in looking at tumors and derived cell lines. So what they did was actually look at the cancer cell encyclopedia and matched that to TCGA and looked at pathways that were upregulated in cell lines opposed to the parent tumors. However, these are not matched. So we were able to provide them, for example, some matched melanoma brain metastasis cell lines. And you can see that they were looking at different markers to just select out the cancer cells and then look at gene expression, what is upregulated in the tumor versus the cell line. So this patient is another patient who came in with a history of a low-grade tumor. He had 4 previous resections, comes in with a seizure. This is his scan. Many of the neurosurgeons in here are going to say, why didn't you just come in lateral from the side? I had to place a bolt for the laser fiber, so I decided to do laser on him. He told me he never wanted a craniotomy. So I said, okay, that's fine. And unfortunately, his bone had been, he had so many surgeries, there wasn't enough bone to actually dock a laser with the titanium bolt. So I had to come from above, and he did pretty well. He ended up going, this is like a year out, very well with laser. And then he comes back with this. So then I do another laser and I do biopsy, and I also send for 3D predict. This is the first patient that I said, well, is it going to work? I only am sending cores from a needle biopsy. And yes, I was still able to get information from the functional assay. So they were able to grow spheroids from a biopsy. Ultimately, then he ended up getting a TMZ rechallenge and further radiation, then comes in about a year later with this. So at his previous laser, he had upgraded to a high-grade glioma. Now, obviously, you don't need PAF to know that this is high-grade. He actually still wanted therapy, and so I ended up doing another laser procedure with multiple trajectories. And he is hemiparetic at this point. He had some improvement, some functional improvement that he became ambulatory, but he only lived 4 months. But again, this is what he wanted. He did not want any more adjuvant therapy. So what this case taught me is that, yes, you can send biopsy cores for 3D predict. And then also, if you're going to ablate a tumor this big, I kept him sedated in ICU. I gave him hypertonic saline. So obviously, this is not like a normal laser case. So this patient is a 37-year-old woman who came in. She previously had a resection at another facility 15 months prior. She comes back with this. She had been shopping around for clinical trials, got turned down everywhere because her lesion is just so large. Many recurrent GBM trials would not enroll a patient with this tumor. It's greater than 5 centimeters in diameter. So I took her to surgery. I also implanted GammaTile, and I thought, well, she has a pretty good functional status. She's young. I'm going to take this out, and we just got GammaTile. I'll do that as well. The other thing is her tumor from her index surgery was not available to us, but I did go ahead and request that it gets sequenced. So here are her molecular markers from her index tumor. Here are her molecular markers from recurrence. And if you look at the tumor mutational burden, you can see she went from 4.2 to 62. Now she's in the 99th percentile. So now she's a candidate for immunotherapy, potentially. So this is just an example. We do NGS at each surgery. The tumor is changing. You can see this is not the same tumor. And you can see how the genomics has drastically changed. Again, we used Julien and we sent for 3D Predict. We didn't get results because her tumor was so heterogeneous, they were not able to really get a good standard curve on the control. And then again, Gametol for her, because she was young, she was recurrent, she was also rural. She blatantly said, I'm not going to come back for radiation. So she lived 8 more months from when she presented. I think about that. This is a philosophical question. Was that worthwhile? Talking to her mother after she died, it was worthwhile. She got to go to Mardi Gras. So one of our clinic visits, we reviewed her medication list and which medications she'll have to stop so she can have a drink at Mardi Gras. So I do think that this was beneficial to her. So now this patient comes in, 25-year-old male. He has a grade 4 astrocytoma, so he is an IDH mutant. He went out of state for an immunotherapy trial. So he went out of state for this immunotherapy trial. You can see the stimulated T lymphocytes. He has this tumor, but functionally he looks way better than his scan. I'm not operating on people who can't walk, just disclaimer. So he was told there's nothing more we can do, but you can contact your home neurosurgeon, see if they're interested in debulking. I've known him for years. I knew he went out of state for this trial, and I told him, okay. His wife called me on the way back. They were driving back from another state. And I said, yeah, I'll do, you have no deficits really. You're slightly weak, but still walking and doing well. I'll debulk you. So I debulked him, and the plan was radiation and Avastin. Unfortunately, he had some wound healing problems, so he ended up just getting the radiation. And then I did a biopsy and sent for 3D Predict. He had brief stability after we put him on a targeted agent. So this is a combination of combining NGS and functional. So he had a CDKN2 homozygous deletion. This is from his NGS results. Then you can look at his 3D Predict. He had a moderate response to a CDK4 inhibitor. So our oncologist felt maybe this is what we should put him on. Ultimately, obviously, we knew we weren't going to get a cure. It came back in a bad location. He became wheelchair bound for the last month of his life. But again, we were able to send 3D Predict with biopsy cores. And that's in combination with our pathologist, making sure I'm not sending them treatment change. But we got down to 6 cores can actually give you results, is what I found. And then also combining NGS and this functionality. And he also got about 8 months. So I think that's a win. So this patient, he is de-identified now. His parents, his family has given me written and verbal permission. This is actually Jacob. He's a 24-year-old male who came with headaches. He has this large left-sided tumor. He came in with headaches. Interestingly, he had colon cancer at age 3. So I got a gross total resection. He was 24. I was very happy. No deficits post-op. I thought, great. But this is him 3 months later. He did undergo chemoadjuvant radiation. And here he is with this recurrence. Locally, our radiologist picked up this little guy across the street or on the other side. That made me really concerned. He had a dural base enhancement. So I did an LP, and he had positive cells in his CSF. He wanted to be very aggressive. So I did a resection of the local recurrence. I resected that little guy. I put in a Maya reservoir, and he ended up having intrathecal therapy. So something that we learned was we do NGS with a matched blood. He ended up having Lee-Fraumeni syndrome. So we identified a cancer predisposition syndrome. Thankfully, multiple people from his family now know they have this. So it's very useful in that. His DNA analysis showed that he had no targetable mutations. So he ended up still living for quite a while, going through multiple therapies. And then we ended up coming up with a plan for him based off of RNA and organoid work. So this is just a kind of rundown of some of the therapy he's had. You can see he lived over 2 years. Again, he wanted to be aggressive, but without ever having deficits. And I told him, if I feel I can't take it out safely, I won't operate on you. But anyways, he had multiple therapies. You can see them listed. And his index tumor was very strange. It had features of ependymoma and xanthoastrocytoma. And so here we're looking at the RNA. So each dot is a tumor. And if you cluster close to another tumor, that means you guys are alike. And so you can see that his tumor is very unique. There is no tumor in this compendium of thousands of tumor that has a 95% correlation. And you can see that his tumor is closer to an ependymoma than it is to GBM or to, for example, low-grade gliomas. But he's all over the place. It's not a typical GBM. He also didn't have any actionable DNA mutations. So we thought, let's use comparative transcriptomics, which is RNA-based, try to identify pathways that we might be able to target. And then we'll actually go into organoid work and see if those drugs work. So here on the left, each dot is a tumor. Here's over 12,000 cancer patients, all different types. And he is in red. You can see he has upregulation of STAT1 and STAT2. Just looking at GBM, he's considered an outlier in this pathway, which means above the standard deviation. So then we generated, we used his tumor as well as some other tumors from our biobank to actually generate an organoid assay where we can test drugs. So here we are testing ruxolitinib, which is an upstream inhibitor of the STAT pathway. And we can see that he at least ex vivo has a good response, as well as patient 23, which also was found to be potentially responsive to the JAK inhibition. Of note, during this time, he kept having tumors. So he was enrolled on 3D Predict. You can see that, for example, one time, EGFR inhibitor was found to be a potential response. So we put him on that. And then he had recurrence within a month. And we took the tissue out, and you can see osimertinib, he no longer responds on his recurrent tumor. It no longer shows a response. So what we think is that it seems like the functional results are actually correlating with the clinical course. Previously, I showed you that everolimus, which is an mTOR inhibitor, seemed to be a potential additional target. So we said, okay, what if we combine them? We put him on monotherapy before, and it comes back. So we combined the therapies ex vivo. There seems to be from his index tumor as well as his most recent recurrences. And we got him to progression-free survival for about 5 months, which is the longest of his course. So we were very excited. Of course, it came back over and over again, ultimately going outside of the brain and even into his lymph node. So what did Jacob's case teach us? Again, something we kind of already knew, but now we have more information. Tumor evolution over time is very functionally different. So this is just 3 of his 3D predicts from different surgical dates. You can see it's all over the place. What about single cell RNA-seq? We were able to do that on a lot of his tumors. So this is before he started EGFR inhibition. This is the cancer cell population of his tumor. Then after EGFR inhibition, you can see the upregulation of that pathway. So we feel like this is going to help us understand how he developed treatment resistance. And then also looking at just in terms of the phenotype. So here, looking at RNA velocity, most of on the left, you can see this is going towards a NPC type of phenotype, but then afterwards, it's actually going towards more NPC migrating. So his tumor is becoming more aggressive, and you can see that on the single cell level. Surgical tissue is very helpful for other things. So this is a patient who had a glioblastoma to the lung. We took that out as well to potentially try to see if we could get therapies. This patient wanted every single thing done, so we were extremely aggressive, but this is actually something we're able to generate cell lines from and looking at data from that. And then lastly, just looking at our patients, we noticed that a lot of patients who don't get radiation, obviously they die. We know that, but can we perhaps circumvent that by doing brachytherapy up front during surgery? So I know I'm going over, so I greatly apologize. Basically, in summary, we just want to use our data to help with understanding the disease, but also for precision medicine. And this is Jacob, one of my favorite pictures of him. So thank you guys for inviting me, and I'm sorry I went over.
I don't think I've ever seen a more fantastic presentation of how a surgeon gets involved in numerous aspects of tissue analysis and scientific application. So congratulations. Outstanding. It's always an issue that everybody wants tissue and they want more tissue. So with your technique, are you able to get more tissue from combining the different approaches you've had?
Yeah, I think so. I think we're really into, I joke with people in my lab that I will go into like canisters, even say someone uses a sonopit, I'll go into the canister of a sonopit and like get tissue and cells. So I think we go very far to get tissue. But sometimes we don't have the capability, like for the biopsy cases. But I do say that we try our best to get as much tissue as possible. But considering the diagnosis, we never want to compromise that.
I see that. Also, you demonstrated very well with your case series the dynamic nature of the evolution and morphological and genetic changes of these tumors. A great demonstration of that. Open up for any questions for Dr. Rodriguez.
Hi, Dennis Watson from Cleveland Clinic. So I really like the idea of being able to in real time change and adapt therapy to your findings. A practical consideration that I was wondering about your insight on is how do you fund this? I'm assuming a lot of this is through clinical trials, but it probably is hard to get buy-in from different drug companies to fund this constantly changing therapeutic approach.
Yes. So I practice in a poor rural state. So a lot of people are like, how are you doing this? First of all, our NGS, we use Tempus. And the reason I use Tempus is because they have a financial clearance form that, and so our patients aren't charged for the NGS. The other reason I use it is because they give me back the raw data. Foundation One is really weird and doesn't give you back the raw data, but I have enough, getting more into bioinformatics that we want to process our own data. So that's why we use that company for those reasons. So that's how our NGS is all paid for, just through clinical. Then in regards to the therapies, so getting targeted therapies is very hard for insurance reasons. That patient I showed you, the one who went to Mardi Gras, was never able to get her immunotherapy because of insurance reasons. But we do go through a lot of processes to, with our cancer center, sometimes they have leftover drugs, or to get things, we directly contact the company sometimes. And so we've been successful in a lot of cases, like with Jacob, to get some of these targeted agents.
Like never before, our neurosurgeons and neuro-oncologists talking to the pharmaceutical companies, talking to the pharmacists, talking to the insurance companies, and having to lobby for the newer treatments that these testings are elucidating. We have another question.
Yeah, excellent presentation. For the cases where you do stereotactic biopsies and also do 3D predict, do you sort of isolate those samples that you send for 3D predict versus for pathology for biopsy, or does it all go to pathology first and then 3D predict after that?
When you send biopsies for 3D predict, I have to constantly communicate. So I have to make sure for the recurrent cases that I'm sending viable tissue. 3D predict will not work on non-viable tissue. So when you're doing an open resection, it's way easier because you have gliolin, and gliolin will, recurrent tumor will fluoresce, treatment change won't fluoresce, and it's like very simple. Once you get into stereotactic biopsy, so I usually have to biopsy in a region, then wait for the pathologist to confirm that it's recurrent tumor and they see tumor. And then if they do confirm that, then I send more cores. And then from my own experience of, I don't know how many patients we've done over I have 40 patients now. So from my own experience of those that are biopsies, I could get down to 6 cores and get a result. So that's the lowest number I've been able to get away with.